So if along the way there are questions, we can come back to you, Ken. But otherwise, thank you very much, Ken. So now, Bancha, we invite you to share your talk on your opinions about cuff repair, to tie or not to tie. Thank you, Bancha.
Thank you, Danny. Um, Good morning and guten Morgen, Prof. Hotel. And I'm talking about cuff repair, to tie or not to tie. So I tell you the story. In the past, I routinely do not tying. But one day, I changed my mind because I have some bad experience with not tying. Okay, thank you, Mytech Johnson, for the invitation today. And also, I found this article from Professor Younger Lee. Yeah, he found that the retaliate is in rotator cuff sometimes very high. Okay, because of the knot tying. The pattern of tear in knot tying in rotator cuff is the tear proximal. We call muscular tenderness tear. From some study, it's up to 70%. Okay, then you can see the video, right? The
Yes,
vessel
Bancha.
obstruct
Yeah.
at the medial footprint. You see that? The
Mm.
vascular. So this is really nice video that you can see that the strangulation at the knot. The vessel cannot go through the footprint. So from this article mentioned about the conventional knot tying, the type 2 tear is up to 59% because you strangulate the blood supply. Like Ken said, if you tie the knot too much, sometimes you cut the rotator cuff, okay, at the proximal, at the footprint. So I did one study about knot tying and knotless. Okay, you can look at the left. This is conventional knot tying. On the right side is the knotless suture bridge technique. Okay, and we measure the average pressure and contact pressure. Okay, we found that using the knotless at the medial footprint, you have less contact pressure, 43% comparing to 51%. This is at the medial footprint. It's significant. Okay, the pressure, contact pressure at the medial footprint, and at the area contact, I mean the pressure distribution, comparing knotless and knot tying, we found that using the knotless suture bridge, we have more pressure distribution and a better contact area. Okay, 76% comparing to 65%. So that can explain why the medial knot tying or the medial row tying, you create a type 2 tear. Okay, and this is my case series. I correct the patients that have type 2 and type 3 pate, and we found that the knotless group, we have less tear. Like type 2 in pate 2, you have only 0% comparing to 28%. Pate 3 also. Okay, so the knotless group have less retaliate. I show you one patient. This is a male, 65 years old. He came to see me because of the rotator cuff tear. But the surgeon did really nice repair. I look at the video. The problem is that he tied the knot at the medial side. You can see that the rotator cuff healed nicely at the footprint, but the tear is proximal to that. So when I get in, I found that the cuff healed really nice. You see the footprint coverage really nice, but the problem is at the medial medial row. There's a tear at the muscular tenderness junction. So I did the muscular tenderness repair. Okay, so I pass the suture to the proximal and then do the suture bridge. Okay, without taking out the footprint because the footprint healed nicely. After surgery, the patient got really good result and the cuff healed nicely after the surgery. Okay, so that's one example. Actually, we have many patients. If I look back, I have many patients that have the same problem like this. So this is my technique of muscular tenderness repair report in arthroscopy techniques. It's like tension band. You just pat the suture to the medial side. Okay, leave the lateral footprint intact and make it like a tension band. Okay, fixed to the lateral row. And we found that this tension-free repair we call a dozen knotless suture bridge because I put 12 suture in the rotator cuff. Okay, there's more anatomic reduction, less dog ear formation, better pressure distribution, and decreased tension at the muscular tendinous junction, reducing the type 2 tear. My friend Juhano told me, "Oh, Bancha, your technique looks so nice. Why don't you put the camera into the joint?" So he recommended me to do that. Okay, he don't agree with me that I didn't tie the knot at all. So this is one patient. Yeah, he has the rotator cuff tear. So after the repair, it look nice, suture bridge, knotless, right? But I put one knot in the back, okay, and one knotless in the front. When I put my camera again in the joint, I found that, oh my God, it's not, the medial footprint is not contact, okay? But if you look in the back, here in the back, this contact nicely. So in the back, I tied the knot. In the front, I didn't tie the knot. So I want to compare. We found that there's some gap in the front, but in the back, the tendon attached to the footprint nicely. Okay? So, those suture bridge technique, I need to think over again. This is good. Okay? Because from the intra-op, I found that there's a gap underneath the rotator cuff. Anyway, this patient, after the surgery, I did the MRI study. We found that the cuff healed, but look like it's not healed nicely at the medial footprint. So I got the idea to do the cuff repair this way. We call hybrid technique. I put 4 sutures in the rotator cuff, but one hole I put 3 sutures in one hole. So that make less damage or less soft tissue trauma to the rotator cuff. And I just tie the knot, only 3 knots, 2 or 3 knots, one in the front, one in the back, and one in the middle. Okay, just 3 knots. And the gap should not be too close. And then we do the suture bridge like this. Okay, we call this hybrid technique. Knotless and not tying. Okay, you can see from the video. Okay, this is the hybrid technique. Okay, and after that we found that the result or the MRI after surgery is look better, and I try to put my lateral as wide as possible. So the anterior one, I put it close to the bicipital groove, okay, to the good bone quality, and the posterior one I put it very close to the infraspinatus, okay, so to make it as wide as possible to increase the pressure contact, okay, like that. So, and sometimes if you have this kind of tear like L shape, or you need to do margin convergence or apex reduction, I always tie this knot because this is a key stitch. If you tie this knot, you will have less tension, and your footprint will not hold too much tension because you share the pressure, share the tension to the knot tying. So like L shape, I need to repair my apex, okay, like this. So we make a raw surface, same way, okay. Reduction, the apex, and tie the apex first, okay, like that. You see that I tie the supraspinatus to the infraspinatus, okay, and after that you can do the suture bridge, okay. Okay, that way. So we found one article. You should not put the suture too close. Say the number is 5 millimeters. If you put it very close and you tie the knot, you tend to cut the rotator cuff. Okay, imagine if you do this way in multiple knots, you may cut the medial footprint. So you should put it average about 6 to 7 millimeters, okay, and you will have the less problem about the cut through the tissue, okay, and also the you have less dog ear also, okay, like these patients have the, if we have a bursal side tear of the rotator cuff, I try to preserve the medial articular surface, okay. I will preserve the articular surface. I will not take down the rotator cuff. This is my bursal side repair, and we publish the technique of the bursal side repair, preserving the articular side. The result is pretty good, okay. So I always do my surgery in bed chair positions, right? And I think the bed chair position for me, it's I can work very well because I can rotate the proximal humerus. Like this patient, she has very big size tear, okay. The key concept is that you need to make a good release before the repair, okay. Like this patient, I try to release the rotator cuff from the coracoid, and you need to make a tension-free repair, okay. Like these patients, they have the torn cuff. I repair the cuff to the apex, okay, like that, and make a suture bridge, like that, okay. And the result is good, quite good. This is a high bridge. Even she has a very massive tear. If you make a good release and tension-free repair, the result is always good, okay. She is quite happy. And this is another high bridge technique, okay. Did the same way. Limited knot tying. Okay, and make a suture bridge. So this is a final repair, and also we put the camera into the joint. Again, you can see that this previously we do knotless, and now we do limited knot tying. You can see that the articular surface attached to the footprint nicely. Even outside look the same, but in the joint you can see that better contact. This patient have massive pseudoparalysis, okay, from trauma. So he had the massive cuff tear, infraspinatus, supraspinatus, okay, big guys, and there's some proximal migration. I discussed with the patient that I will try my best to fix your shoulder because this is the traumatic and he's neglected for many months, okay. But finally we can reduce and can save his rotator cuff again, okay. So I found that this high bridge should be my final solution, okay, because now I correcting the data, comparing this high bridge and the knotless. We found that we have better results, okay, after this technique, okay. So this is after surgery, and finally he's getting better, and he's big guy, see, nearly 2 meters tall, and you see his cuff healed nicely, okay. Medial footprint, lateral footprint, yeah. So we have many patients that have very massive tear. We use this high bridge technique, and the result is pretty good, okay. So this is the last patient. We have some experience with the Dynacord, the new one, okay. Professor Hertel was going to talk about that. So I have some experience because it just launched to Thailand, this Dynacord, okay. We do the fixations, suture bridge, okay, like that. So this one, another patient. Sometime when you tie the knot, and you can see that this suture is loose, right? This suture is loose, I rotate the shoulder and found that this suture loose. Okay, and this is very good idea. You see that this dynacord, the tension can be better over time. So I tried this dynacord in one patient. This is a very massive tear. Okay, so after the repair, just a very big size tear, supraspinatus and infraspinatus. Okay, so after the repair you can see that, and then I wait for a while. Okay, you can see that this suture is getting bigger. Okay, this dynacord suture. Okay, but I didn't have the clinical result yet. So in conclusion, the knotless and knot tying, for me, I think I'm in the middle. I do hybrid technique. Okay, I do limited knot tying. We make less hole. Most of the time I put about 4 holes in the rotator cuff and do limited knot tying. That should be less trauma to the rotator cuff, less blood supply disturbance, less strangulation, and it's very fast, less operative time. Thank you.